Welcome to Iswam Virtual 2021.
Good morning, everyone. First of all, I would like to thank to everyone for being here with us today. It is my pleasure to welcome you all to the Iswam Virtual. I am Dr. David Budiwartono, will chair the session for the session 3 of face contouring and volumizing. This session will cover some important points of face contouring, volumizing, and the second session will cover also about filler update, contouring and not volumizing. And the first speaker will be Dr. Felix Lee. Good morning, Dr. Felix Lee.
Good morning.
Thank you.
Thank you so much, Dr. David. Good morning, Iswam. Good morning, Indonesia. Very, very happy to see everyone again. Today, we are going to talk about how to achieve natural and lasting results with fillers. So, my name is Dr. Felix Lee, and I work at my own clinic, Dr. Felix Lee Medical Aesthetics Clinic in Singapore. Now, let us start by asking ourselves, what is our goal as filler injectors? What makes a filler treatment successful? I think the most important thing about filler treatment, a successful filler treatment, is two things. Firstly, the patient must not be able to look, it's very important that the patient does not look unnatural. We want the patient's friends to say, wow, you look good. You look slimmer. Have you been exercising? You look fresh. Have you been sleeping well? We don't want the patient's friends to ask her, have you recently done something to your face? Did you inject something in your face? Because that immediately takes away the essence of the treatment itself. So I want to start off by showing you this patient. She's 50 years old. This is her photos after her fillers were done. If you look at her, can you tell me where the fillers were done? We take a look at her face in static as well as her face in expression. Can you see where the fillers were done? So with that thought in our minds, I would like to say that the patient looks natural, her expression is natural, and she does not look like a great deal of work was done on her face. But now, let's compare her to the before. And there you see what changed in this patient. She's 50 years old, and we did one session of fillers with only 4 cc of voluma, and this is what we got for her. So a lot of people think that they will say, oh, I went to this clinic and I got very subtle results. I like it because it is subtle. What the patient is trying to say is she likes it because it is natural. Subtle means there's a very little change. When a patient pays this amount of money, they go through downtime, they go through risk to do an aesthetic treatment, they do not want a subtle change. The change has to be a very important change that you can see on the before after photo. But yet, if you look only at the after photo, like we did at the beginning, it means natural looking. So it is important, I feel, for filler treatment to give the patients natural results. But when you compare the before after photos, you see a big improvement. And I would consider that only the beginning of a successful filler treatment. What's interesting about this patient is that over the past year, she actually missed her next treatment because of the lockdown. Because Singapore's in lockdown, she couldn't come back for treatment. So she went almost 2 years without her fillers. What we did for the Iswam talk a few months ago was to ask her to send us a photo of how she looks, a photo taken at home by herself with almost no fillers in her face because it is almost 18 months since her last treatment. And this is what she sent us. This is how she looks 2 years after the first filler. So she still looks young, she still looks fresh, she still looks lifted, but 2 years on, there is almost no filler left inside of her face. And if you compare to her before photo, you will find that this patient remains improved even when the filler is gone. So today we are going to try to take you through the thought process of how to make a filler procedure give patients results that are natural, at the same time a big change from the before, and most importantly, results that will last long after the fillers are gone. And this is a true anti-aging result that you can create for your patients. Okay, now let me ask everyone another question, and I hope you will think about this, the answer in your head. I wish I was there in Indonesia to ask this question live. How many cc does it take to overfill a face? Now, as aesthetic doctors, or even as anybody on the street, people will look at other people's Instagram, social media, and say, "Oh, she must have got a lot done. She must have done a lot to her face. Maybe she had plastic surgery." Now, what gives people that impression? And why is it so that as aesthetic doctors, when we see a patient who has had a lot of work done to her face before, we immediately know that a lot has been done to this face? What is the visual cue that lets us know that this face is overfilled? And how many cc of fillers do you think it takes to cause that appearance of being overfilled? Okay, so I hope we all have an answer in our minds. Okay, the video is a little bit slow. Let me show it from my desktop instead. Can everybody see this? Okay, thank you. Okay, so this is a little experiment that we did in clinic to illustrate a point that I'm going to make. One interesting fact to share is that anatomists around the world would agree that if you took away the volume of the skull from the head, the total soft tissue volume of the face is around 100 cc. So this is fat plus retaining ligaments plus collagen plus skin. Everything put together is around 100 cc. That is the average volume of a 70 kilogram human face. So we filled 2 glasses with 100 cc of water to represent the volume of a human face. And what I do now is to inject 4 cc, the amount I most commonly use in my liquid facelifts, into one of the cups. Now, I'm going to hold up the cups, and can you tell me which cup has more volume? It is very, very, very difficult to discern 4 cc's of volume visually. But when I give talks and I say that, well, in this case, I did 10 cc, 12 cc, 16 cc of fillers, the crowd will always go, whoa, there will be a murmur in the crowd. And people will always think, is that too much? Is the patient going to look puffy, overfilled, unnatural? So what I did then was to inject another 12 cc's into the cup with the 4 to give it a total of 16 cc of volume on top of the 100 cc of natural volume. Now, my question to you is, when I mix up the cups, can you tell me if the cup with 116 cc is cup A, this cup, or is it cup B, this cup? Is anyone able to tell? So the point I'm making here is that you can inject up to 16 cc of volume into a patient, and it is not the volume that makes the patient look unnatural or overfilled. Let me expand on that concept a little further. This is a photo of me taken at Iswam 2019. I thoroughly enjoyed my time there. I love the enthusiasm of the crowd. I love how everyone was so engaged in the presentation, and I thank Iswam once again for inviting me. But can you tell what's wrong with this photo? There is something wrong with this photo. Can you tell? Okay, let's hold that thought and look at the next photo. Can you tell what's wrong with this photo? There is a woman's head on my head, isn't it? So immediately you know that this photo was doctored. This photo is not natural. Okay, firstly, I would like to apologize to this participant right here. If you're watching, thank you very much for letting me use your face without your consent, because I couldn't find you. To illustrate a really, really important point. In the first photograph, there are 8 of these ladies. This is her. And we put in 1, 2, 3, 4, 5, 6, 7, 8 more, 7 more of her into this photo. So we Photoshop 7 more of her into a photo. It should look unnatural. Now that I pointed out to you, I'm sure it looks unnatural. But when you first saw this photo, did you notice that this was done? Now, if you did not notice that there's 8 of her in this photo, it is because while we have increased the volume, we have placed it in a place that is natural. Our eyes are always meant to pick up differences. Unnatural to us is a way that something does not normally look. Now, this participant is supposed to be this size, in this resolution, sitting on this chair in this position. So even though there's 8 of her, you may not have noticed. But if we so much as inject one point that is completely out of place, like in this photo with her head on my hands, immediately any onlooker can tell that this photo is unnatural. This photo is doctored. So the most important thing about how to not make a patient look unnatural is not how much we inject, but how and where we inject. This, of course, is the original photo. Now, a really, really important thing to remember is that conceptually, what we need to do is to replace volume where volume was lost with age, to restore support where support was lost with age. We do not want to create new volume unless we are contouring, like we're creating a lips, chin, nose, okay. But in terms of a facelift, we do not want to create volume where volume was not there before, because that makes the patient look unnatural immediately, especially in expression. You do not want to restore support in lines, in vectors where the support was not there before, because once again, it makes the patient look unnatural. So in order to restore support and volume in a natural way, we have to first understand how our face ages. And I decided to break it down into a very, very, very simple diagram. Every retaining ligament in our face, that is an osteocutaneous ligament, will tether bone to skin. And where the bone is, the ligament is firmly supported. Where the skin is, the ligament is not as firmly supported. So look at this ligament right here. Let's imagine that the firm support is on this end and the weak support is on this end. The ligament is holding up soft tissue fullness that most commonly consists of facial fat. What happens with age? Gravity works equally on the ligament, whether the support is firm or the support is weak. So when the force is the same, what do you think will happen to this ligament? The ligament will droop where the support is weaker, relatively more compared to where the support is stronger. And what happens when the ligament changes position? The fullness that it was holding up will drop down accordingly. So what happens here is that you will see a downward descent of certain highlights of the face, leaving behind a hollow where the fullness used to be, and a line or a fold where the fullness now is. So this is something really important to understand, because when we are trying to treat aging, we are trying as much as possible to reverse the mechanism that caused this appearance of the face to change due to aging. We want to do it in the reverse way as much as possible so that our treatment will always restore a natural appearance for the patient. How can we change our mindsets as injectors? If we saw the hollow and we filled the hollow, is that natural? That's not natural, because the hollow is, in most part, for most patients, not a result of volume depletion. If volume was lost and we're putting volume back, then that is natural. But the hollow was not caused by volume loss. In fact, many studies have shown that even in very old age, the total amount of facial fat remains largely the same. The loss is actually much less, but the hollow is significant because the fullness has moved downwards. So if we replace the hollow with volume, you are going to get a face that is very, very full. because there is the fullness that was originally there, plus the fullness that you're putting in a large amount of to fill the hollow. So then you will get a pillowy, puffy appearance of the face. And that is not always ideal. But let's say with good techniques, with good fillers, we manage to do this in a way that looks nice, that looks aesthetically pleasing. It is still not going to be a long-term solution for the patient because we have not put the face in a mechanical advantage against the forces of aging. So once the filler is gone, the results are gone together with the filler. Nothing has changed. And you have to inject again and again. And once again, that leads us to a higher chance of causing a very overfilled, puffy appearance. If we fill the line or the fold caused by the descent of the original fullness, what we're going to get is fullness around the line and fold, while a lot of times the hollow remains there. Now, what I mean by this is that if you directly fill the fold, which is actually a skin fold downwards due to descent of the fullness that's above it, you fill the hollow below it. The hollow is not a real hollow. There is no hollow there. There looks like there is a fold because the top bit is coming down over it. And if you fill that up, there's two problems. Firstly, once again, you are causing the face to be puffier. And secondly, you are actually closing off a space that was natural to the face. And what is the problem with that is that there are soft tissue spaces in our face, all over our face, for a very, very important reason. Because our faces need to express. We need to talk, laugh, and cry. And when your faces express, it contorts. After it contorts, it has to go back to its original position without being totally contorted, permanently contorted. So it is really important to leave these spaces alone, because once you fill these spaces up, your patient will immediately look very unnatural on expression, because her expression will be either limited or in a way that is not natural. And of course, you can see that the worst case scenario here would be to fill both the fold and the hollow. And then you're going to get fullness over the entire cheek, and you are not going to have any discernible facial spaces. And you end up looking exactly like what people always say. She looks plastic, she looks overfilled, she looks unnatural because the entire cheek is one big pillow. That is not how the human face looks like. So when you are restoring a face, we are trying as much as possible to restore it in the opposite way of how it changed, and not, as I mentioned before, to put volume where volume was not there before, or support where support was not there before. So stop injecting hollows and folds. Instead, what we do is restore support and reposition ligaments. If we can inject fillers in a way that restores support to the weaker part of the ligament, what we can do is reposition it to a position that is closer to where it was when the patient was younger. And this movement of retaining ligament will naturally move the fullness closer to its original position. So immediately, what you are going to get is an improved highlight of the face. The face now looks more youthful because the fullness has moved to where it was when the patient was younger, right? And you don't have to use a large amount of volume. And the patient, the most important thing for this patient is that you have actually restored a mechanical advantage against the forces of aging. Because when the fillers go away with time, the ligaments do not drop back to where they were pre-treatment. The ligaments will slowly drop due to gravity, due to the natural process of aging. So you have given the patients not just an aesthetic improvement, but an anti-aging result if you inject fillers well. Sorry. So how do we do that? I like to call this functional anatomy because I'm not going to discuss where the anatomy is. I'm not going to discuss landmarks. I'm not going to discuss blood vessels and all that. I just want everyone to understand a concept of anatomy that affects the way we inject as filler injectors. I split the face into just two halves. Okay, if you draw a line from the corner of your brow down to the corner of your lip, everything behind that line is one half, and everything in front of that line is the other half. Now, the posterior half contains muscles of mastication. So these, mainly the masseter muscle, of course, and these muscles are used for chewing. So these muscles have to be very strong for us to chew, to break down our food. And as a result, the mass over these muscles are relatively fixed. The muscles in front of that line are meant for expression. It's meant for us to convey the way we feel. So these muscles need to move. They need to move freely. And as a result, the mass in this area is relatively mobile. Now, what's really important to understand is that the fixed mass and the mobile mass are continuous. So if you rejuvenate the fixed mass, it will also lift the mobile mass. So that is a really, really important concept to have. And you will see it in the design I'm going to share later. Now, I split the face then into 5 layers, but we only want to focus on layer 4, retaining ligaments, because based on what we described in the earlier slides, the most important thing is to restore support to these retaining ligaments, to reposition them to a state that they were in when the patient was younger. Now, the important thing about layer 4 is to know that layer 4 in different parts of the face exists in different planes. Like, for example, if everybody knows that when you restore support to the temples, you will get a brow lift, you will get a lift of the corner of the eye, the patient's eyes open up. Sometimes a double eye that they had when they were younger but was lost when they were older will be restored. And as we will discuss later, this is due to support of the superior temporal septum and the inferior temporal septum by filler injections in that area. But do you notice that when patients do collagen stimulators to the temple, what it does is that it can fill the temporal hollow very well. It can probably fill the temporal hollow more than fillers can fill the temporal hollow. But what it does not do is all the lifting that I mentioned above. Why is that? Because the collagen stimulators are injected subcutaneously, and that is in layer 2, not layer 4, where they can influence the above mentioned retaining ligaments. So at the same time, if you inject, so therefore if you inject the temples, you want to inject deep to the bone to get as close to layer 4 as possible. But at the same time, if you go down to the pre-auricular area here, layers 1, 2, 3, and to a large extent 4 are actually very, very tightly adhered together. They're stuck together. So do you inject to the bone here? Obviously, you can't inject to the bone here. You will have to go through the parotid gland to do that. But do you inject deep? No, you don't. You inject subcutaneously. Why? Because when you inject subcutaneously in this area, you are actually supporting layer 4, the masseteric ligaments running through that layer, because the first 4 layers are so tightly adhered together that subcutaneous is already at layer 4. So the take-home message in this slide is we want to focus on rejuvenating layer 4 if we're aiming to do a facelift, a non-surgical liquid facelift. But it is important to note that layer 4 is in different planes, in different parts of the face. So with all this information in our minds, how then do we design a treatment that can work for any patient? I call it the simplest facelift. Once again, I'm using an elegant picture because I didn't invent this facelift. It is my derivation of the MD codes, which is the way, a method of injecting fillers that Elegant teaches. But whatever fillers you use and whatever method you use, the most important thing is that we have to conceptually understand what we are doing with the filler to confer the improvement to our patient. So my simplest facelift is like this. First, we need to support the temples. Immediately, we improve the hollowing, the shadow here, that makes the patient look old and tired. Why? Because we are restoring support to the temporal ligamentous adhesion, this area, which is formed from the superior temporal septum and the inferior temporal septum. And when you restore support to this area, you are actually restoring support to the lateral eyebrow, the upper eyelid, as I was mentioning previously. Then we want to support the cheekbones. Where we're injecting into the cheek highlights, the area that makeup artists will highlight with the makeup to give the shape of the cheek. And what we are restoring is zygomatic ligaments. These ligaments, smiling ligaments. And what that does is provide support to your lip corner and your jawline. Next, we want to work on the pre-auricular area. This is a really, really important area to treat. Where you actually see the change immediately is the subzygomatic hollowing. Some patients can look very gaunt, very, very thin and old because of this hollow under the cheekbone, especially in Asians with prominent cheekbones, because it makes the difference look greater. But what makes this injection so important is that it supports the masseteric ligaments, a series of masseteric ligaments that in turn provides support to your labiomandibular folds, your jowls, and your jawline. It gives you a lift this way, and it defines definition of your jawline. Lastly, we treat the piriform fossa, or so-called the nasolabial fold. I am never trying to fill up the nasolabial fold, because the nasolabial fold is a natural line of expression. Babies have nasolabial folds, and filling up the nasolabial fold will immediately make the face look unnatural. What I am doing is putting a support in the floor of the pre-maxillary space, almost like a cushion or bed for the volume of the cheek to lie on top of. And of course, what it does then support is the middle of the cheek. I call this facelift the simplest facelift because you can do this facelift, you can do this design on young patients who are not saggy, they're not old, they're young, but they have started to show signs of aging. You can do this to restore ligamentous support. So the patient actually ages better with time because you are putting the ligaments in an advantageous position, a position where they were when they were younger. Let me just side track a bit to talk about this. Do you notice that when you are young, very young, when you are 13, 14, 15, 16 years old, your face looks the same every year? It doesn't change. Your face actually starts changing when you go into your 20s, and you notice that change gets faster and faster when you get into your 30s, your 40s. You will actually notice that the face changes more every year as you get older. Now, why is that? The reason for that is because when you're younger, the ligaments are very, very firmly adhered. They are very strongly supported. The total force is actually greater than the force of gravity. The face does not change. But once these ligaments start getting looser, they start getting laxer, and they start changing position, it actually takes them out of that area of mechanical advantage. And now, with gravity working on your face every day, your face will change. And the greater this disadvantage, the faster your face changes. So when you do the simplest facelift for a young patient, you're actually slowing down that process of aging for her. You're restoring support for her. And more likely than not, you are also going to highlight her face, improve the contour of her face, and make her look more attractive. But you can do the same simplest facelift for an old patient who is already saggy, who is already looking tired, looking sad, looking old. And what the facelift will do then is actually two things. Firstly, it will restore volume. It will restore volume to certain parts of the face, which will make the patient appear less gaunt, less old. But most importantly, it will restore support. And in this case, it will not just restore support, but it will actually lift. And the patient will see a very big discernible improvement once you do that. Because when you age, the volume moves downwards, but it cannot indefinitely go downwards because it is ultimately bounded by the skull of your face. So what happens when you age is that the facial triangle reverses. The volume of your face goes downwards and outwards. So the patient's face actually looks wider, saggier. And the moment you restore support, you are going to pull this inwards and upwards. So the patient's face will then restore a more youthful contour. And most importantly, I know I'm drumming this point in, is that we are slowing that process. We are slowing the rate at which the face changes with age. And that is a result that the patient will not see immediately, but it is the result that will make the patient come back to you every year once she knows what you can do for her. Okay, so how do I do the simplest facelift? It is really simple. In the temples, feel the corner, the left lateralmost corner of the orbit, retract the skin, and inject deep to the bone. I use 0.7 cc of volume in this area. Then I go down to the cheekbone. If you feel the curved aspect of the cheekbone, and you go backwards, eventually you will feel a notch on the cheekbone itself. Try it, you feel the curve, and then it goes straight, and you feel a notch. Once again, pull the skin back, inject directly into that notch, 0.1 cc, 0.1 cc in front of it, 0.1 cc behind it, or along the cheekbone. Why do I split it up 0.1, 0.1, 0.1? Because then you get this very, very nice highlight of cheek, just like how a makeup artist would do it. Pre-auricular area. Now, this is an area that if you went back 20 years, the very rudimentary sort of plastic surgery, this was the area that plastic surgeons would use to do the conventional facelifts, surgical facelifts. What they would do is to open up the area, retract the SMAS, either reflect it, remove it, and to oversimplify it, stitch it back together. So we are doing this to the face. We're doing this, which is the original facelift. The strength of this surgical facelift, of course, is that there is a great deal of lift, and it can make an old patient look much, much younger. But it is also very tight, and it will leave a scar in front of the ear. So what we do now is we approach the same space non-surgically with fillers to expand, remember our theory, to expand the SMAS backwards, laterally, this way. We provide support here to fix SMAS to lift up, in consequence, the mobile SMAS that is in relation to the fixed SMAS. And how do we do that? We draw a line under the zygoma. That is the superior border of the space we're trying to look for. We ask the patient to clench the teeth, and then you find the anterior border of the masseter. That will be the medial border. And with this line and this line, you connect then this line to the triggers of the ear. So what you will then get is a parallelogram or rhomboid-shaped space, which is the pre-auricular area that you can approach with a cannula. Why cannula and not needle in this area is because firstly, the space is big. Needle injection will have multiple, you need multiple points for needle injection, and that can lead to problems like bruising or damage to surrounding structures like parotid gland. But more importantly, remember what I said before, that in this area, layers 1 to layer 4 are very, very tightly adhered together. So once you find a subcutaneous space, with your cannula, you will be in layer 4 throughout the injection. And that will give you the best results. It's not too superficial to cause lumpiness, and it is not too deep where it will cause a lot of pain, discomfort, and damage when you are actually scraping against the capsule of the parotid gland. So what we do is subcutaneous fanning with a cannula, and I use 0.7 cc in this area. Lastly, Piriform Fossa. That is straightforward. Next to the nose, deep to the bone. Why deep to the bone? Because this area is a danger zone. Hence, you see the red circle I put over here. Because the facial artery runs upwards through this area in its course. So, where is the facial artery? A lot of people will say, oh, it is 1 cm, it's 0.5 cm, it is upwards, downwards, lateral. No. The facial artery has many, many, many different variations in different people, and it is not a landmark that you use to avoid it. It is a plane. The facial artery is not on the bone. The only place that you can be absolutely sure that the facial artery is not on is the bone. So in this area, you inject deep to the bone, keep the needle on the bone, aspirate, no blood, put in the 0.3 cc bolus, simple and safe. What happens when I want to put volume as well? It is actually the same rule. I will always put more volume into the posterior half, then volume into the anterior half. And this is a straightforward concept of mechanical advantage. I want more here for lifting and less here for volume. So for example, if I did my simplest facelift, if you remember, 0.7 plus 0.7 plus 0.3, I have placed, and both sides, I have placed 3.4 cc of fillers in the posterior half. And I put only 0.3 in the anterior half. But what if the patient's cheeks are flat? Sometimes after the lifting, you get very nice contour, very nice support, but you must also beautify the patient. So what happens if the patient's cheek is flat? You've got to put some volume. It's the same. I am going to put 0.2 into the SUV, 0.2 into the teardrop, and 0.1 into the lateral teardrop. So once again, when you add everything up, you are still putting more volume posteriorly than anteriorly. And if you do that, no matter how you design your filler, it will always confer a net mechanical advantage to the patient's face. Coming to the end of my talk, I just want to quickly say, what can we do as injectors? Is our job to make the patient's chin sharper? Is our job to make the patient's cheek fuller? Is it even to make the patient more beautiful? Actually, we can do a lot more for our patients if we can produce results for them that will transform not just their face, but their lives. If we look at this patient, she's 50 years old. She works in sales, direct sales, point of sales. So, of course, she will feel disadvantaged compared to the younger colleagues in her workplace. Her face has the classic hollow, fullness, hollow, of an Asian face. Her eyes look tired and droopy. Her cheeks have segmented and has dropped down. And of course, you see jowling and sagginess in the lower face. So what changed in this patient is age. She is an attractive person when she was younger. I looked at her photos. But what made her look like this today is just age. So what we do is we do the simplest facelift and we restore her to a state where she looks younger. The contour of her face is closer to that perfect reverse egg shape. Her eyes are more open. She looks less tired. And once you do that, you can do a little more. Like in this case, we put in some chin fillers, we put in some threads, just to give that little highlight, that little bit extra, that makes her go to work feeling confident, not feeling disadvantaged compared to her younger colleagues, but feeling confident about herself, about the experience that she brings. At the same time, looking like an attractive woman, a woman who looks age appropriate, but beautiful for her age. We can restore our patients. This patient, of course, she's only 43, but she lost a lot of weight in a very short time due to a serious medical condition. And as she made a full recovery from that condition, it is not just her medical condition that improves. You have to also improve the psychology, the thinking of this patient, of how she would look younger, how she would look fresher, how she would walk out of the episode of her life and put it behind her. And this is what we can do as injectors. Give me 1 second, I need to plug in my computer, sorry. Okay, continuing. Lastly, we can transform. This is a patient who is obviously beautiful. She's young. She's a very successful businesswoman. But what we can do for her is to elevate her beauty to the next level. If you look at her photo here, you can see that she is beautiful. She has very, very captivating eyes, very, very nice features. But if you look really closely as an injector, you can see that there is a flatness of the cheek. You can see that there is signs of jowling. You can see that there is loss of definition of her jawline, which is why she hid it with her hair. And most importantly, you can see a retrusion of the chin backwards. So even with all of these aspects, this is still a very beautiful young woman. But if we did also the simplest facelift for her, just to restore that support, to improve the highlight, to put her face into a situation where she was younger, and to improve the contour of her face by improving the contour of the chin, the jawline, this is what we can do for her. If this photo looks familiar to you, it is because this is the face of the Clarins advertisement board in Singapore. I'm not sure if in Indonesia they use the same model for Clarins, but this is what we can do for our patient. She is young, she is beautiful, but if we take away the negative aspects, the negative messages that her face conveys, we can elevate her beauty to the next level. And when you put all this together, the first patient, second patient, third patient, I did the simplest facelift for all of them. It's the same thing, and based on what they need, we tailor treatments subsequently to that's specific to this patient. But the baseline is we do the simplest facelift for everyone. Why? Because the simplest facelift supports every single retaining ligament of the face to put the face into a youthful, attractive situation that has a mechanical advantage to resist the forces of gravity over time. And this is the concept of injecting fillers that I would like to share today to help us understand better how to achieve natural and long-lasting results with dermal fillers. With that, I thank you very, very, very much, everybody, for your time and attention. If you would like to discuss anything related to fillers or aesthetics with me, you can find me on Instagram at Dr. Felix Lee or email me directly, drfelixlee.j@gmail.com. Thank you very much, Dr. David, Sari, the wonderful Iswam team, and I wish Iswam Conference the greatest success. Thank you.
Thank you, Dr. Felix. Anything to ask about fillers and also contouring and also how to correct the chin and the cheek, please use your time and write on the Q&A box and ask the Dr. Felix. Okay? Let me check again. Is there? Miss Sally, can you check the chat room, please? Some of participants say that there's no voice. Okay.
I have a question, Dr. David.
Yes, Dr. Felix.
Did you see the 7 faces the first time round?
Yeah.
You noticed it the first time round?
Yes, I noticed that.
Okay.
Yeah. Because usually we do a small thing, so when you show that, why that face look the same? Or but I don't count. But I just noticed
You are
why the
very, very
face.
sharp. You are very sharp.
Yeah. When we do a practice of aesthetic, we all get used to see the small things behind.
So
It's
true. That
just
is
a
very,
practice.
very true.
So please, I got a message. Oh, the participants said that the last answer they cannot hear because maybe the technical problem or the connection problem. So can you repeat the answer? I repeat the questions. When we use the cannula and facing the retaining ligament, should we dissection the ligament first? Can you repeat the answer, please?
Yep. No problem. So I was saying that you can't actually dissect the ligament, but what you are doing is that, yes, when I do cannula, I will do a little bit of blunt dissection of the area. It is not to dissect the ligament, but rather to dissect any fibrosis, adhesions, or scarring under the skin to release the skin such that when the retained ligament is lifted, the skin will move nicely with it. So that's the reason for dissecting the area, is to dissect away any fibrosis, adhesions, or scarring, not so much to dissect the retaining ligament itself.
Okay, so that will be good answer. And if any of you have a questions, please write on the question and answer. And I hope Dr. Kisanti satisfied with the answer. The sound is back. Okay, so we only have 2 minutes left, and there is no questions again on the systems. So I think we can close the sessions. Thank you very much, Dr. Felix. It's very nice presentation and very happy to see you in the Iswam, even though we have the lockdown everywhere in the world, but we still meet on the this platform and we still share something. Thank you
Yes,
very
yes.
much for presentation and explanation. See you and please stay safe.
Thank you so much. Thank you so much.
Thank you.
Thank you.
Bye bye.
Bye bye.
So we prepare for the next presentation. Before that, for the participants, you can watch the advertising for little bit. Hello, welcome again and the second sessions of the third session of Face and Contouring Volumizing. And now we welcoming for the next session Dr. Olivia Ong, and we will talk about the filler update contouring and not volumizing. And how are you, Dr. Olivia?
Hey, I'm good, Dr. David. How are you there?
I'm good also here. Thank you for
Okay.
being a
Yeah.
presenter here.
Yes.
And I will mention about your CV. Dr. Olivia has bring the commitment to perform the art of aesthetic medical science to its highest degree, concentrating exclusively on non-surgical procedure to enhance the face, body, and anti-aging. Dr. Olivia study in S2 Anti-Aging Udayana University. S2 is bachelor, right?
Yes.
And also medical doctor graduated from Atma Jaya University, and the last working now is medical director of Jakarta Aesthetic Clinic from 2015 until now. So we will start about the topic, the second topic of the day, contouring, not volumizing, and the time and place we give to you.
Okay. Thank you, Dr. David, for a beautiful introduction of me. Thank you, International Iswam, for the opportunity. Talk about aesthetic, talk about filler, talk about contouring. Because volumizing, because face contouring is a part actually of face. Face volumizing is a part of face contouring. We don't only volumize the face with filler, but beyond that, we contour them. Here is the precaution. You can't depend on filler only to treat aging. It will lead you to create unnatural look and facial overfill syndrome. Quick look for the whole concept of aging process. Skull. Different by race. Here we are, Asian, have a broad face, projecting cheekbones, edge-to-edge bite, and narrow flat nose. Different by gender, so we can't contour them the same. Actually, the skull guides us from the frontal bone, orbital rim, zygomatic bone, angular mandibular, and chin. Different by age, maxillary reabsorption during aging makes the orbit and piriform aperture size increase. Zygoma becomes more retropositioned with aging. An increase in maxillary reabsorption is associated with decrease in skin fat and collagen contents, leads to mid-face soft tissue descent. While the mid-face recedes, the forehead suffers continuous expansion. The mandibula also loses its vertical projection. The mandibular angle becomes more obtuse with increasing age, and the chin becomes more oblique and shorter with increased anterior projection. Let's move to the rest. Soft tissues. Superficial fats are located adjacent to facial mimetic muscles, more metabolically active and more prone to hypertrophy. Meanwhile, deep fat lies directly on the facial skeleton and has tendency to selectively atrophy over time. Because this compartmentalized appearance, there are hypertrophic hills and atrophic valleys on aging face, which actually allowing us to precisely and directly augment selected deep fat compartments. Understand the aging process fully actually really help us and our patients satisfied with natural long-term result. And help our patients spend their money wisely, especially in this pandemic. There is line of ligaments, an imaginary line that connects temporal ligamentous adhesion, lateral orbital thickening, zygomatic ligament, and mandibular ligament. The arrangement of soft tissue layer is different with respect to the line of ligament. Medially oblique, like roof tiles, and laterally parallel, like onion skin. Placing filler differently, medial or lateral line of ligament result in different effect. Injecting medially result in volumizing effect, whereas injecting laterally result in lifting effect. This has been tested by split face interventional study, and the results show if lateral injection points are performed first, the volume injected to the medial line of ligament reduced plus or minus 30%. Because lateral injection have a stretching and flattening effect of the mid-facial soft tissues. Now we take a closer look to transverse facial muscles. Gray shadows right adjacent to the inferior aspect of the zygomaticus major muscle indicate a transverse facial septum. The deep mid-facial fat compartment are indicated by the orange area, which changes its position during smiling. It is important asking patients to smile repeatedly during filler injection procedure, to avoid facial overfill syndrome. I'd like to talk a bit about filler because temporal region is the most promising facial region for inducing pan-facial effect. Temple has anterior and posterior part, which divided by vertical line passing through the middle of the zygomatic arch. We are familiar with treating anterior temple. Here are two techniques to treat posterior temple that result a lifting effect on the middle and lower face. Number one is supraauricular lifting technique. The cutaneous access point for this technique is located in the anterior third of the zygomatic arch, lateral to line of ligaments. Product is applied to the subdermal plane of the posterior temple, 22G, 50 mm cannula, bevel up position, advanced toward the superior aspect of the auricle. Small doses of 0.1 to 0.2 cc of high G prime or high elasticity product equally distributed around the superior and anterior aspect of the auricle. A larger bolus can be applied anterior to the tragus to treat a local depression here. Total amount less than 1.2 cc. Cautions: post-injection pain due to mechanical compression of the auricular temporal nerve in layer 3 and posterior to the parietal branch of the superficial temporal artery. Number two is temporal lifting techniques. This technique is very good for helping to lifting the lower face. Product is applied to the subdermal plane, layer 2 of the posterior temple that covered by hair. This technique can enhance the appearance of the jawline, the jaws, the labiomandibular sulcus, and in some cases, nasolabial sulcus. The cutaneous access point is located here, 1 centimeter anterior to the apex of the tragus. A 22G 50 mm blunt tip cannula is inserted subdermally and bevel up. Strict subdermal cannula advancement is required to avoid displacement of the cannula into deeper planes by lifting the entire length of the cannula and ensuring its contours are readily visible. A bolus of 1 cc of high G prime product is administered slowly without movement the cannula. Patient open their mouth to relax the muscle and no massaging is recommended. Caution here is superficial temporal artery is located in the same 2D location but in layer 3. A deeper product application can potentially result in an intra-arterial injection which can affect large area of the scalp, the soft tissue of temporal fossa, and the perioral region due to transition of the material via the internal maxillary artery. Non-scarring alopecia has been observed potentially due to compression or intra-arterial application of the follicular arterial plexus there. Cases has resolved spontaneously without other intervention. Understanding this concept optimize mid-facial treatment. Remember the line of ligaments? If lateral to line of ligaments are targeted first, the volume needed to treat the mid-face is tactically reduced. So the same concepts apply to the temple. Don't forget the importance of treating the nose, the chin, and the jawline to contour the face. For the rest of my presentation time, I would like to talk a bit about rheological tailoring. Now we are using different injectable products on the one's face, like an artist uses a palette of paints to create complete picture. The perfect picture when you combine your knowledge of rheological tailoring with a safer injection technique. Understand each product characteristic and applying safer injection technique with the most natural looking results. Here are 3 words describing our work to patient face: lifting, supporting, and sculpting, which detail have been presented. 2 important rheological properties are viscosity and elasticity. High viscosity confers the advantage that the filler will tend to remain where it is injected rather than spreading out, allowing us for precise sculpting. High elasticity or high G prime confers the advantage of resistance to applied forces, example from facial musculature and gravity. Here are some products studied for their viscosity and elasticity properties. Studies support high viscosity and elasticity filler provide more efficient volume replacement and tissue lifting. Example, calcium hydroxyl apatite requires smaller volume than that required when HA filler with a lower viscosity and elasticity was used to achieve optimal nasolabial fold correction. HA wins for lips because they are translucent. Perioral region because their lower viscosity and elasticity property could decrease the risk of contour irregularities. A low viscosity and elasticity will tend to spread into the tissue and have a softer feel. A higher viscosity and elasticity will feel firmer and tend to spread less. About the technique. A high viscosity and elasticity filler will be less palpable within the tissue if it is injected with serial threading or cellular puncture rather than large boluses. Conversely, the lift of low viscosity and elasticity filler can be augmented by injecting larger boluses through cellular puncture. Calcium hydroxyl apatite, our new friend, has controversial data before, but in the last couple of years, a clear evidence has emerged on safety and tolerability of calcium hydroxyl apatite filler for over 17 years now. Calcium hydroxyl apatite doesn't stimulate any local or foreign body reaction or adverse systemic effect. The big cells surrounding the microspherule are chemotatically attracted by microspherule constitution. They become fused with one another, and following a specific stimulation by the microspherule, they undergo differentiation. Gel carrier is digestive. The digestion of such material is responsible for the lack of compactness of microspherule content and of a slow release of the calcium hydroxyl apatite microgranules into the closed extracellular matrix with a diffuse smoothing effect on the skin. After 2 months, there is a stimulatory effect on fibroblasts. The abundance of rough endoplasmic reticular and Golgi in fibroblasts show this stimulation may be due to cohesive gel carrier associated to calcium hydroxyl apatite in the microspherule. It means On the basis of morphological evidence, injected calcium hydroxyapatite filler doesn't only give volume and support to the connective tissue with an aesthetic result, but also has a positive effect of stimulating fibroblasts to produce new matrix with an effective renewal of the skin connective tissue for beyond HS filler. The consideration only on reversal agent not available currently for calcium hydroxyapatite filler. Last but not least, stay safe and thank you very much.
Thank you, Dr. Olivia. Any question for Dr. Olivia? Thank you, Dr. Olivia, for your presentations. I will check that question and answer before we continue. And let me see first. It's no questions yet until now. So please, participants, for you who listening this symposium, if you have any questions for Dr. Olivia, please write on the questions and answer, and I will read for you. It's a lot of things that we should know about the characteristic of the filler, right?
Right.
Yeah, and usually people always mention about the calcium hydroxyapatite is because it cannot be dissolved, it could create a potential danger. What do you think about that?
Actually, it is dissolved. It's actually calcium hydroxyapatite consists of 30% of calcium itself and 70% of gel carrier. And naturally, calcium is dissolved over time. And the good thing is, it's not like calcium calcium, the chemotatically, the big cells like to come because of the gel constituent.
Ah,
Yes, not
that's
because
it.
of the calcium hydroxyapatite itself,
Hmm.
but they fuse together and then they somewhere go differentiation
Yes.
that makes the the gel constituent, the 70% gel constituent getting less, and then reducing the compactness of calcium hydroxyapatite itself.
Mm-hmm.
The calcium hydroxyapatite itself will be like releasing its micro granule. So
Ah,
before they
okay.
have a size bigger, and then they become like less and less because of the digestion.
Okay.
And then
So,
because of the compactness reduced, it will like spreading around the dermis of the skin.
mm,
Not only giving like we inject to the angle mandible, giving the exact volume projection like that or contouring, but also the skin itself having uh, getting better over time by
yeah.
fibroblast
So
stimulation.
it's a
Yes,
double effect like volumizing and also the rejuvenations, right?
right. And it's
Oh,
really fall beyond the HA fillers.
okay. That's
Mhm.
a good thing to know. And hope we will have a lot of questions for you. How is sharp needle approaching layer 4? Can you please answer, please?
Sorry, Dr. David, I didn't hear your.
The question is from Dr. Kishanti.
Yes.
Comparing the layer 2 with cannula, can we use sharp needle approaching for layer 4?
Hmm. Dr. David, I lost you again.
Hello?
Yes, Dr. David, now I can
Yes.
hear you.
The questions from Dr. Kishanti. Comparing the layer 2 with cannula, can we use sharp needle approaching layer 4?
For,
Yes, using
for,
sharp needle.
for treating.
For filler, using
Yeah.
sharp needle approaching layer 4.
For treating what area?
The 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 doctor doesn't mention what area. Oh,
Oh,
this one,
okay.
the temple region, for the temple region.
Okay. So there is actually now from a publication that I read from the 2020, the new one, yeah. There are 6 different injection technique for the temple, and maybe Dr. Kisanti mean for the anterior temple.
Yes.
Anterior temple. Usually we are familiar for gunshot technique from the orbital rim and temporal adhesion, 1 centimeter up, 1 centimeter behind. Yeah. For that injection, yeah, we approach really bone. And I sometimes for the anterior temple using combination, if too deep, I combination with layer 2 two. Combination.
So we use combined blunt and sharp needle.
Yes, but for the posterior temple, it is recommended to use the cannula because of the special precaution that I mentioned on the presentation, and for the achieving the area further and border, but safer, like that.
Okay, okay.
In layer
So
2, not layer 4.
in layer 2, okay,
Yeah.
okay. So it already answered the question. Next, Maria Angelina, cheek lifting using filler.
Cheek lifting using filler.
Yes.
Okay, first you can approach with the temple injection from anterior and posterior temple first, and then because lateral injection first will reduce the amount filler you need to inject on your medial face. And then for the cheek itself, we see because when we see our patient when they're not expressive, we can see, oh, what fat compartment is need attention. Usually deep fat compartment. So when we inject deep fat compartment, we inject deep to the bone. Let's see how it goes.
Okay.
Ask the patient to smile because the temporal septum that I mentioned about is like the same plane as zygomatic muscle, yeah, and make the deep fat pad, the medial fat pad can change during expression. And
Okay.
when we see the injection volume, CC volume good when patient still in still position, maybe it's too much when they're smiling. So just put the CC under dose first and Let's see when the patient smile, and better you do under correction rather than over correction,
Yes.
because the skull formation for Asians really broad and really flat. Mhm.
Okay, that will be the answer for Dr. Maria Angelina. And the last but not least from Dr. Ubeta, is there any granuloma formation after injecting calcium hydroxyapatite too superficially?
Okay, injecting. Okay, from the journal I read couple of journals since the new one 2018. There is a report for risk of granular formation for calcium hydroxyapatite is none. But if we inject too superficial, yes, we can feel the filler, because the filler actually is like harder or more rigid than HA filler. So, but that's okay. If we find like that, we can massage the area, or we can inject NaCl or saline, or even now with newest publication, we can also inject in the nodules. We call it the nodules, not granuloma, with combination of dexamethasone, triamcinolone, and 5-fluorouracil for the resolution of calcium hydroxyapatite nodules.
Okay. Let's check again. One more questions, Dr. Maria Angelina. Continuing the first questions, the first one was, what are your best tips for cheek lifting effect using filler? And she continued the questions, is the temple injection enough to create lifting effect?
Yes, the temporal injection will be enough for mid until moderate SEGI, or yeah, laxity, mild
Mm,
until moderate laxity of the skin. So patient is different. Every patient is different. Sometimes young but have a laxity, moderate laxity. Yeah, but that's okay. We still approach from the lateral first, then do medial approach first, because it will really reduce it will really help to lift the mid face, to lift the lower face in different degree, and finally reducing the amount needed for injecting filler in the mid face. The mid face really can be so funny if we inject it too much, a bit too much, or sometimes the doctor and the patient don't recognize it until someone or other doctors that understand about uh, overfill syndrome have tell about that, then patients start know about that, or doctors, oh, like that. I hope it's not happened to us, because we are know about facial overfill syndrome, and I also talk about facial overfill syndrome often in every seminar, like Dr. Ting Song, the first. So hopefully we can maintain our patient face natural longer, right? Because
yes.
getting older, patient face is not getting more beautiful actually. But if we do like uh, overcorrection from really keen to injecting filler, or filler only without combination, without thinking the long effect, it's really very easy to go to that direction.
Yes. Yes. The beautiful part of the aesthetic medicines is we must have the courage to learn the art of face, and it includes inside of this overcorrections, minimal corrections, how to create a natural beautiful and not to create weirdo beautiful. You know what I mean with the weirdo beautiful, right? because sometimes they asking for the very high uh, fat here, so they looks like a very so maleficent things, like not the beautiful human things. And sometimes they are happy with a very long chin and also a very high nose, and which is not natural for their bone structures. So when we learn the art of the aesthetic, the art of the face, and we knew this part is overcorrections, this part is minimal modifications needed, and we will create a natural and beautiful face, and people does not see that as a fake.
Mm.
People will see that as a very beautiful young woman, and that is our achieve in the aesthetic medicine, right?
Right. So don't look like the face has been done filler injection like that. Just subtle changes.
Yes, yes,
Yes,
yes, yes.
all the
Let
time. All the time.
Okay, we have no more questions in the Q&A. So I'm asking for the Miss Sari, can we finish this, because the time we still have looks nice, looks younger, and looks beautiful. It's not beautiful like a beautiful fake, but it's really really like a natural one. And that is the ability of medicines in aesthetic field, using a filler by a natural contouring technique for the cheek and the form the filler, and also defining which part needs contouring and which part needs volumizing. And after all, thank you for these presentations, Dr. Olivia. All the questions in the box already finished. And I say for the Iswam, thank you very much for being here. Thank you very much for sharing your knowledge. And thank you. Please stay safe and see you later on the next symposium.
Bye.
Bye bye. So we can close this, and for all the participants and for all the attendants, thank you for all attentions, and we believe that this session will bring us more knowledge and benefit to all of us to be the better practitioner. And it is my great pleasure to chair these sessions today. Don't forget to join our next sessions